So thank you, Arup, and I'll be talking on design of fast IOL and changes till foldable IOLs. I have no financial interest to disclose. So this was the generation 1 IOL that lasted from 1949 to 1954. This was the original Ridley posterior chamber lens. So everyone knows Sir Harold Ridley performed the first IOL implantation on November 29, 1949. This groundbreaking procedure revolutionized the field of ophthalmology. His method was executed in 2 stages. First, he performed the ECCE, and then 3 months later, he proceeded with the IOL implantation. This strategy was designed to maintain stability in the ocular milieu following the ECCE to avoid any negative outcomes. This is a photograph that was extracted from an original film and subsequent videotape of Ridley's 8th IOL implantation performed at St. Thomas's Hospital in May 8, 1951. This is a gross photograph taken from the Miyake view post-mortem, shows an eye with a properly centered Ridley IOL. This patient had bilateral implants and enjoyed excellent vision for 20 years prior to her death. Then this company, Rayner, was born, and the part share was held by Sir Harold Ridley. The problem with IOL power calculation in Ridley's lenses arose because they didn't consider the variation in refractive index between the proteins of human lens and the plastic of the IOL. Consequently, original lens ended up being excessively thick, and the first patient's refraction revealed high myopic overcorrection of over 14 diopters. Ridley was ostracized for a time from the mainstream of ophthalmic surgery and was forced to abandon his original posterior chamber lens due to complications. It is dangerous to be right in matters on which the established authorities are wrong, by French philosopher Voltaire. Then Ridley's contribution was recognized from the year 1976 to 92 by the American Academy of Ophthalmology and Otolaryngology in San Francisco, then by the European Implant Lens Council in Jerusalem. Then the Royal Society of London gave him knighthood, and then subsequently got the Gallstrand and the Gonin medals. Then came the generation 2 early anterior chamber lenses. In 1950s, a new breed of IOLs are born, which are more stable as it was supported at the angle. Technically, it was very easy to do the surgery, and it could be implanted even after ICCE. Baron implanted the first AC IOL in May 13, 1952. It had a shape of a thick convex disc bent towards the endothelium, leading to glaucoma and corneal decompensation. As you can see over here, it was a thick lens which was almost touching the endothelium. If you compare it to the modern day anterior chamber intraocular lens, you will see that there is a huge difference in the thickness of these 2 lenses. Then Stampelli began implanting the tripod lens in 1953. It became the prototype of rigid AC IOLs. The problem was correct sizing, because the size of the eyes were different, the angle to angle measurement was different, so the sizing was a huge issue. Then Peter Choice came up with this particular IOL in 1956, and it modified up to 1 to 9, Choice Mark 1 to Choice Mark 9 in the next 13 years. On the right, you will see a picture of Choice IOL implanted in a patient's eye. The problems were again corneal decompensation, bad manufacturing techniques, residues on the lenses from sterilization process, and fundamental design flaws leading to serious inflammatory reactions and erosion of the fixation elements in the UVL structures. Then came the iris supported lenses. Those are the generation 3 lenses. So this was a collar stud lens developed by Epstein, and you can see it's a collar stud lens on the left hand side top. And then came the Maltese cross lens and the Copeland lens. This is a Maltese cross lens on the bottom. And this generation lasted from 53 to 75. Then Binkhorst developed these iris clip lenses 4 loop in 1957. And then he developed iridocapsular fixation in 2 loop in 1965. So these are the two lenses, on one on top, the 4-loop, and on the below, it's a 2-loop lens. Again, it pronounced iris pigment epithelial defects and atrophy occurred. Pigment dispersion glaucoma occurred, corneal complications occurred. So again, these became obsolete. Then Binghorst developed this first iris clip lens, 4 haptics, 2 fixated in front of the iris and then 2 behind. Binghorst again developed 2-loop iris clip lens for iridocapsular fixation. Fedorov modified this design to Fedorov 1 and 2 and named it Sputnik due to its appearance, 3 haptics in front and 3 behind the iris. Then Wurst came up with this particular lens. It's called the medallion lens, developed by Jan Wurst, included 2 fixation holes, and through these fixation holes, sutures were passed and these were sutured into the iris. But however, biodegradation of nylon sutures caused lens dislocation. In 1970s, Wurst develops the iris claw lens. It's called a lobster claw lens. You can see over here there are small gaps which you separate and tuck it with the iris. On the right, you can see a Wurst lens in place. Then Singh modified this into Singh Wurst iris claw lens, which we have all seen. Then came the generation 4 intermediate anterior chamber lenses. So these were ACIOLs with flexible or semi-flexible haptics, Sarjidev style Lieski lens, Silco Optiflex ACIOL, IOLab Azar 91Z lenses. So all these had open or closed loops. These again caused corneal decompensation, pronounced uveitic reactions, erosion of the anterior chamber angle, ciliary body area, cheese cutter effect by closed haptics, taken off the US market in 1987 by the FDA. Then came the generation 4B lenses by Kelman. This was the lens with 3-point fixation, also called the pregnant lens. And on the right is called the normal ACIOL, which we see today, is a Kelman multiflex ACIOL. Then came the generation 5 lenses with improved posterior chamber lenses. This was the first PMMA PCIOL by Pierce. It is a tripod PCIOL developed in 1975. Then came the shearing J haptic PCIOL in 1977. Then Anis PCIOL with closed circular haptics in 1977. In the 1977 PCIOL with open J haptics introduced by shearing represents the prototype design for the PCIOLs that we see today. The looped haptics were first made using flexible materials such as polypropylene. During the following years, many variations to the haptics were made, and it turned out to be a single-piece PMMA lens. The haptic designs were modified J haptics, C haptics, and modified C haptics. And then come the generation 6 lens, which I'm now going to speak about. This is a modern capsular posterior chamber lenses and modern anterior chamber lenses. If I have seen further, it's by standing on the shoulders of giants, Isaac Newton. So what we are seeing today is we are standing on a shoulder of a giant and seeing it further. Thank you very much, and special thanks to Dr. Padmavati Bhattacharya and Dr. Dipanjan Pal for the research. Thank you so much.
Thank you, Ayan. It's a wonderful talk regarding the history of the IOL. So, we are actually standing on the shoulder of this giant. And today we want to say something, Siddhartha.
The initial Ridley lenses were PC lenses or AC lenses?
PC lenses.
This is a PC lenses.
So
ICC came later. Okay. ICC came much later than the ECC.
Okay. So these were initially they were all PC lenses,
and
then it became AC.
AC lenses.
Then they started doing ICC and putting AC.
See, everyone forgot who invented the IOL until David Appel started researching this thing and reinvented that Harold Ridley is actually invented.
Right.
So,
This is really interesting.
actually, he was a dumped. So this is a very pathetic history if you go through this history of IOL. So far we have reached, there is a cutting edge